And then we go. Okay.
Oh, fuck. I look ridiculous.
Okay. So welcome to this session. I am here, Francesco Burzotta from Rome, and I am together with a very good friend, David Hildy-Smith, who will be moderator. Why we need a moderator? Because you probably learned during this PCR the fact that in session like that we have both you in the room, but also people at home, and we want to engage all the people at our maximum. So also we will have as a discussant Adrian Benning, and we really get the benefit of being really companions with the other countries, and Yoshi Murasato is connected remotely, and he will be the remote discussant. As a chat matter, we have Rosine Colleran, and without losing more time, we start the session. So this session is entitled Left Main Bifurcation, Latest Clinical Data Applied to Practical Cases. The session objectives are to discuss cases of left main PCI from EBC main trial and ROLEX registry. Cases are very nice. We like really to get inside the cases and coming outside from the numbers of trials to understand why and how adapt the stenting strategy to the side branch disease, and to learn how to use intracoronary imaging to improve outcomes. So why this session was designed? We have, in the last 3 years, worked a lot in Europe on left main PCI, and the EBC main results of trials comparing 2 different strategies in patients treated with the Onyx stent was published last year, and Hildy-Smith, David was the principal investigator. And today, in the morning, there was at this late-breaking trial session at PCR, the publication regarding the ROLEX registry. A total of 917 patients with unprotected left main underwent PCI have been prospectively enrolled in Europe and treated with a single type of drug-eluting stent, which has platforms that covers up also large vessels. So all of this amount of data should be discussed and reviewed together. So enjoy the session and be active as much as possible. So, David.
Yeah, so first case is going to be presented by Adrian Banning. It's going to be a presentation of a case from, I think, EBC Main.
Dave, Francesco, thank you very much, and thanks for the opportunity to present today. These are my potential conflicts. This is the case, 2016, 80-year-old man who previously had laryngectomy for cancer, 10-year history of hypertension, raised cholesterol, typical angina, which was restrictive, and normal left ventricular function. This was the coronary angiogram showing a 1-1-1 bifurcation left main stenosis with probable calcium. The right coronary is dominant but non-obstructed. The surgeons, in view of the laryngectomy, did not want to take him on, and therefore he was a candidate for PCI. We thought he was a candidate for the trial, as he had a 1-1-1 bifurcation. And so I'd ask the group, how would you treat it? I'd ask it in 2 ways. 1, how would you treat it provisionally? And 2, how would you treat it outside of a trial? I'll perhaps just leave that to Luke.
So, I mean, I think that to say that it is obvious that this kind of lesion is directly sent for PCI, I think that is something that we may discuss about, because this is definitely very complex lesion, honestly. And when we see this kind of lesions, we have in mind the fact that we may end up with very good result at the end with our drug-eluting stents. But we also should have in mind the fact that the procedure will be complex, and it is not just a problem of a single or two stents. Even with one stent, we may have complex procedure because the complexity is inside the disease. So my first reaction is the fact that this is, according to my interpretation, a complex PCI we are going to have. And this is the first aspect. The second aspect is we should do our best to do not translate a complex procedure in a complicated procedure in terms of complications, clinical complications. So this should be the job probably of this session, trying to understand if there is a flow of working that may avoid to transform complexity in complications.
Yeah, and we should say there are microphones around, so if you feel like make a comment, please do, because we'd be keen to hear from you, because there's only 3 of us up here. In response to Adrian's question...
Could you perhaps loop the cine up on the screen for us?
Yeah. So in response to Adrian's question, I pretty much do all of these the same, which is helpful, because then I don't forget what I'm doing. But so a wire into the circumflex and a wire into the LAD, that may be quite difficult to start with. Because it's the left main and it's going to be more calcified, more fibrotic, more rigid and bigger, some kind of debulking of whatever sort you have access to, from the sort of poorer end of the spectrum, be it cutting balloon, to the richer end of the spectrum like shockwave, so something like that, followed by stent from LAD into left main, followed by POT, followed by recross into the circumflex and do a KISS, and then at that stage see what you're left with. And if you have miraculously, because this is a pretty grim case, got a good result with that, then you won't need a second stent. If you do need a second stent, that's fine, and in this case it would probably be a mini culotte.
So let's have also the benefit of Dr. Murasato.
Yes. According to the side branch region length or calcified region, stenotic region, we perform the 2 stenting technique or 1 stenting provisional technique. According to this angiography, I think LSX region is not so serious. 75% stenosis. I would like to perform the left main calcification ablation, root ablation, and then probably the side branch stenting is considered.
Okay.
Before we go on, there is a comment from the audience. Somebody has asked about hemodynamic support. Maybe we could have a show of hands. Who feels on first? What was the LV function like? Did we know?
Normal, 60%.
Okay. Yeah. Who's feeling enthusiastic about hemodynamic support here? I'm going to put both my hands down low.
Okay. Okay, but I think that it should be emphasized the fact that it was pretty normal, the LV ejection fraction. So, I mean, this is an important piece of knowledge in the presentation of the case.
And the right coronary was normal, which I think is also relevant.
Yeah.
Okay.
Fine.
So he was randomized in the trial to provisional, and I think that had a bearing. I think probably I did exactly what Professor Murasato suggested, which was I was going to try and rotablate this electively. I thought this was a rotablator case. So I crossed into the LAD, and I did rotablation with a 1.5 burr. The result of that was disappointing.
That's pretty unlucky, isn't it? You don't really expect that with rotablation.
Yeah, I thought that. I thought that's not supposed to happen with rotablation.
But it happened
But
at
it
the
happened.
end. Okay.
And Actually, what was even worse was I couldn't then get a wire into the circumflex. So what should I do now?
I would phone a friend, and, you know, because you don't want to lose that circumflex. What do you think the mechanism was of losing the circ? Just
hard for me to say.
Yeah,
But it was there when I started.
Yeah, and you hadn't wired it at all prior because
No,
you'd
well,
done rotablation.
yeah. Rotablation 1.5 burr. I told the fellow that would make some space, and it would then allow us to probably wire the circ, and then everything would be great.
Yeah.
And,
Maybe go back and start the case again and put the wire in the circumflex.
Okay, so
And the question, I guess, in my mind was, I was going to try and do this with one stent because it was the trial, and therefore the one stent was going to go to the LAD. I was kind of committed to that. I think outside of the trial, I would probably, my normal technique would probably have been to rotor into circ first. That's what I would tend to do if I could wire it.
You were allowed to do that?
Yeah, well, that's what I would normally do.
So I want to reflect on this. Several times, repeatedly, we say that rotablation use in the main vessel when you have a complex bifurcation should not translate in a problem in the side branch. I mean, I think that this is commonly said at meetings and Congress, but it is still a technique that requires the fact that you are doing something in the main vessel without the protection of a guide wire inside the side branch. This is basically something that is a limitation as compared to the general approach for bifurcation, that is to have the two wires since the beginning inside the side branch and the main vessel. So I think that to share a case like that is important, because anytime we have the doubt, using or not rotablation in a bifurcation, in a measured bifurcation, we should remember the fact that it is feasible. We know that most of the time it works, but we will remember Adrian Benning, very expert operators, reporting inside a trial something like that.
Perhaps I could ask Professor Morisato, would you have used a smaller burr, 1.5, or would you have gone, I used 1.5, would you have used 1.5, Professor Morisato, or 1.25, or 1.75?
My question is, do you have experience with rotablation with a second wire in the CX or anywhere? I always feel that could be even dangerous to damage this wire with a rotablator.
Yeah, you're not supposed to do that.
Yes.
I would never put a second wire next to a rotablator.
No.
No.
That would be bad.
Yeah. Okay. So I mean, how are you planning to get into the circumflex? You presumably used a variety of wires, sort of hydrophilic, non-hydrophilic, etc., etc. Is there a role for IVUS, perhaps, to try and remind you where the ostium of the circumflex was? Or
there's a kind of slither. I can kind of know where it is. Just kind of the wire to go down.
Yes. I mean, you've got to keep trying, basically.
Yeah. So what I did was I tried a small balloon. So I dilated it with a 2 balloon.
What?
The left main, round the ostium of where the circ had been. So a kind of pot.
Yes, a sort of pre-pot.
Yeah.
Yes.
And then got a Gaia wire. And actually, it found its way down.
There you are.
So I was then able to pre-dilate it and stent it. My view was, despite this being a provisional case, we had now seen occlusion of the side branch, and we might like to discuss whether that always necessitates a stent. It does in my mind. So I stented the circ with a long stent, I potted, and I kissed, and I did an IVUS to the LAD. And that was the IVUS to the LAD, which I was pretty pleased with.
Yes, can I make a point about the fact that you've got 2 stents here? It's completely fine. It's part of the provisional strategy. It's just people always think provisional. Oh, that's a single stent strategy. It isn't. It's a keep going until you get a good result strategy. In the majority of cases, that means you do actually have a single stent. But it's perfectly fine to end up with 2 stents. If we need 2 stents, you end up with 2 stents. That's fine.
And in fact, I don't think it had any material bearing on what was going to happen in this case, in that probably something was going to go down when I rotablated anyway. But what I didn't do, is I didn't IVUS the circ, partly because I kind of had enough. I was kind of 3 kilos lighter than I was when I started, and kind of had enough. And he was fine for 15 months, but then he came back with recurrent angina, and this was the appearance. I don't know whether we can play that again. So he's still not a candidate for surgery. Any thoughts about how one would tackle this?
Yeah, I mean, it's always slightly more difficult once you've got 2 stents in. I mean, it's one of the many advantages of a simpler approach in the left main where possible, that if you do have restenosis, you can convert it to the culotte at that time. For example, now you've got 2 limbs, we can't see exactly what the anatomy is here. I mean, you don't really want to put more stents in if you can avoid it, but I think it's going to be difficult to avoid. And I guess what you'd be trying to do is probably stent left main to circ and do a provisional with a balloon treatment, possibly even a drug-eluting balloon to the LAD. I mean, we've only seen one image, but that would be my first thought. What about Francesco?
Okay. So let's hear the position of Murasato.
Yeah, in this situation, I would like to check the malapposition or stent apposition. So adequate stent expansion is necessary for the left main bifurcation, especially in this region, the very severe calcified region. So the IVUS should be done in this situation. So guidewire link to the LCX and check the LCX ostium expansion and the left main adequate expansion. As you know, 5, 6, 7, 8 theory for the 2 stent to reduce TLR. In the previous session, I recommend such kind of stent expansion check is important.
Yes, so I think that to summarize, we have, we know that imaging might be important. In the case it was not done during the first procedure, at least in the second procedure, it makes sense that we try to fix it our best. Adrian, what you did?
Yeah, and my thoughts were, firstly, I've obviously got to get a wire into it, and these were the options: drug-eluting balloon, lithotripsy, further stents. I certainly wasn't expecting to get the rotablator back out. We managed to wire it relatively easily, pre-dilated with 2.5 balloons. And as you said, we then did IVUS. And in truth, I mean, perhaps predictably, there wasn't much neointima. You know, the stents were not hugely underdilated. You know, there wasn't a really tight napkin rings there where I could say, oh, that's the problem. It was all just probably a little bit small, but not optimal. And the same thing in the LAD. In fact, the LAD kind of looked okay. So under those circumstances, I wasn't quite sure what to do. So we did aggressive balloon dilatation. We could clearly get appropriate expansion, and consequently went on to do further stents. I chose to put 2 further stents in a clots fashion, a mini crush fashion, using a different type of stent in this case, and got that angiographic result. And you can see that there's much better expansion in the circumflex throughout than there was in the first case. And I think in retrospect, this was the final IVUS that we achieved. You can see the double stent layer and a much better minimum lumen area second time around. And the LED really looks pretty good. And although on the angiogram, the ostium in the LED still looked a little bit tight, the MLA in the LED was over 7 centimetres at the ostium. And he was discharged on aspirin clopidogrel and has been well for the last 4 years. So what are my kind of take-home messages? Well, I guess probably I didn't perhaps do such a good job on the circumflex as I might have done. I certainly didn't image it, and perhaps that was the weak point of the case. people talk about stents being crushed. I'm never sure what the mechanism of that is. Do stents get crushed, or do they never? Were they just never big enough in the first place? So I'll leave that floating, and perhaps you can discuss that. But that's the case. Thank you.
Thank you. Thank you very much. Adrian, really, thank you for sharing. I think that we discussed the step by step, and at the end, the message went through the core of this session. I mean, trying to optimize, not thinking that it's easy. Anytime we trying to learn and to correct our errors, and all of this is part of what we try to improve. So next speaker will be David, and he will share another case, probably from, again, EBC main.
Thank you very much, Francesco. Okay, so left main stenting case with IVUS, it's actually not from EBC main, but it was very recent. So the patient was a 79-year-old French man living in England. I apologise to him at the start for our stupidity. He had been admitted with breathlessness and small troponin rise and had had an angiogram done. Prior to this, he hadn't really had any particular symptoms of note. So that's the left-sided image, and that's the right. So he was referred by his cardiologist for bypass surgery. 2 weeks later, because that's what usually happens in the NHS, the surgeons had completed their preamble and they'd had a good look at him, and then finally they'd had a proper look and thought, ooh, actually, maybe this isn't a very good idea. Could you do something with stents? And I don't know if that happens in your institution all the time. It happens in ours all the time. Does it happen in? Yes.
All
okay.
the time.
Good. So anyway, so he had a 2-week vacation in hospital unnecessarily before they eventually decided he's a poor candidate. Can you do some stents? So he was randomised in the optimal trial to IVUS-guided PCI. So I won't show the right, I mean, it was pre-dilated and stented, and that was fine. It was obviously the thing that had actually brought him into hospital, but no one was going to leave the left main because it was tight along its length, really. And I think you can see it's a pretty calcified, unattractive-looking set of vessels. I should add that by this stage, I don't know what they'd been doing to him on the surgical ward, but his creatinine had deteriorated to 200 and something, and so contrast was limited in terms of what we could do with the procedure. So we started with some, I mean, I don't know how the panel feel about this, but I mean, I sort of feel if you're going to do the pre-dilatation, you've actually got to do it really properly in the left main. So there's no point just making a space. You've got to use something which will either debulk or at least cut or open up the vessel properly. And in this case, that means the 3.5 millimeter AccuForce balloon, which was used initially, and then followed by, in this particular case, a cutting balloon. I didn't think IVUS was necessarily going to help us, particularly before doing some pre-dilatation, but we could obviously discuss that. It was quite tight left main. Might have got tighter, obviously, with the IVUS. I apologise for the sort of not very sophisticated recording of the IVUS. Our online image is not working, and so I had to make a phone call, say to our registrar, could you possibly send this to me on WhatsApp? Well, anyway, so that's my disclaimer. So here was the IVUS picture after we'd put in a 3.5, I think, by 30 or thereabouts stent, and you can see it's still, I mean, it's not horrible, but it's pretty compressed and pretty rigidly calcified along there. So we've definitely got more work to do. Do you want me to stop at any stage so you can lambast me?
Yeah.
Yes, okay.
So, yes, so Dr. Murasato, let us have your insight. You are very expert with all imaging modalities, and you were calling for its use. So,
Yeah. Is this image after stenting, left main stenting?
Yes. Angiographic.
So it is difficult to add the rotablation or something. So how about the IVL, retinopathy, shockwave in such situation?
Yeah, good idea.
In Japan,
we don't have it.
We don't have any yet. However, in Europe, so shockwave is available. In such case, shockwave will work very well.
It's sort of perfect for shockwave, you would say.
It is really, yes.
So why did you use the technology from 1983?
Oh, I see. Oh, yeah, that's a bit harsh. We don't have shockwave, actually, for reasons that I can't go into, but we will do. But so we don't currently have shockwave.
Because it looks pretty calcified. I mean, by any stretch of the imagination. So
Yes.
I would certainly have probably just rotablated and lost the circ.
Yes, no, yes, rotablation possible.
But
What would
the
you have
issue,
done,
of course, now
Francesco?
is you've kind of got the stent is now in the way a little bit. For you trying to modify your calcium. So which obviously is perhaps less of an issue with lithotripsy, but you're now really sort of restricted to brute force and ignorance, aren't you?
Yes.
So you asked me what I would do in this condition. Honestly, I want to be honest. In the case there is calcium, most of the time our first approach is to use one-to-one selected to the vessel-sized non-compliant balloons. If they expand well, we know that calcium will remain there, but we will also can anticipate the fact that we will be able to displace it to create a lumen. So honestly, I am really very confident in using the bulking modalities, shock waves technology, especially when I see that non-compliant balloons do not open properly, and we use, as you mentioned, appropriately sized balloon in order to check the final expansion of the stent. I don't know if it is better or worse, but it is what we do in our practice, honestly.
Yeah. So we also have access, I mean, this isn't 1983, but the OPN balloon, which goes up to 40 atmospheres. So I think, you can still do cases like this. So we took a 4.5 millimeter AccuForce balloon to the left main.
Did you say you'd used cutting balloon, Dave?
Yes.
Tell me about cutting balloon. And I mean, I've pretty much given up with cutting balloon, but lots of people still use a lot of it.
Yeah. What do you want me to tell you? What?
How often do you use it?
I use it quite a lot. I mean, I think it's quite useful so long as you actually size it to the vessel size. What's not useful with the cutting balloon is just to sort of waft it around in the middle and hope the razors do something, because they're not going to. But as long as you actually have the right size cutting balloon, you're basically doing a sort of linear episiotomy of some sort on the calcium. Sorry. You're making a cut on the calcium and therefore allowing your stent to expand better. I think it's reasonably useful. Who likes to use a cutting balloon? Yes, look, there's loads of us here. You're the dinosaur.
I'm just the guy that can't get it into the lesion. So it doesn't seem to work when it stays in the guide catheter and it won't go in.
Upgrade to seven French guiding catheters.
Okay, so basically what we did then was we had 4.5 AccuForce, and I mean, you go up to 30 atmospheres quite comfortably. I mean, the balloons are amazing, the pressures that they will.
And the IVUS made you confident that you were okay using that size of balloon.
Yeah, I think
Yeah,
so.
that's an important point.
No, absolutely, very important. Because the left main was clearly diseased along its length, and angiographically, of course, you could only see 2.5 millimeters of lumen. So what size is it? Is it really attenuated? Perhaps because he's diabetic and there's been remodeling, or is it more normal size? So I think it's really, really helpful there. I mean, it's hard to do a good job without that. And then we did, I think, an OPN, if I remember rightly, right on the ostium of the LAD, because that was the most restrictive bit. So you can see, I mean, further down the vessel, it's...
The OPN tends not to PIP.
Huh?
The OPN tends not to PIP, which the other ones do. I mean,
Yeah, because it's double.
I think it's quite good.
Because it's double layered.
Yeah.
So yeah, and that will go up to 40 atmospheres quite happily. And I suppose part of why I chose this case was that it isn't perfect by any means, but it's a good example of the kind of stuff that we're faced with commonly now. Okay, if we have shockwave and that's the answer, that's great. But these kind of cases where you have to end up, and I think, sorry, that's the best IVUS image I got. But what you end up with, I hope this will play, is something which is adequate without being amazing, and you sometimes have to accept that. You are never going to turn this into a beautiful set of coronary arteries. And I think to have kept it relatively simple, because effectively what we've done here is prepare, then put in the stent from LAD to left main, then do a pot, then our IVUS, realize part of our proximal stent in the LAD in particular is not very well expanded, go at that again, quite hard, very high pressures, repeat the IVUS and feel more confident that we've opened it to a good minimal luminal area, and then accept that, okay, all the arteries don't look beautiful, but if he does get recurrent angina, there are things that we can still do. And perhaps, I suppose, the point of the case in a way is that we used 40 mils of contrast in this case, and we really couldn't have used much more. And had we decided to go on and try and make the arteries beautiful, we would probably have run into complications either through contrast use or through the anatomy.
Okay, thank you.
Thank you.
Thank you for sharing. I think that we may discuss a little bit regarding this later phase of possibility to optimize the result in the side branch in terms of, let's say, opening the struts. Professor Murasato, what do you think about the possibility to open up or not the side cells toward the circumflex? This was huge circumflex in terms of territory supplied.
According to our follow-up OCT study, the big side branch ostium had, if we gelled the side branch ostium, the stent thrombus attachment is frequently occurred. So the 3 years follow-up data showed the side branch ostium area is narrowing. Such kind of the large LCX ostium, I think of the open up clearly is very important.
Okay, so you have a very, extensive experience, and I think that this kind of studies are really deserved in order to better find the role for side branch intervention in left main PCI, since side branch may become the target lesion in the case some circumflex disease will develop, but we also know that any manipulation carries the risk, like David said, of further dissections, further need of stent. So, it is typical data we are looking for. I also would like to mention the fact that there is the KISS trial actually recruiting, in which left main is not part, but also randomizing patients to the optimization or not, that also will be important outside the left main. Adrian, what is your perspective on this? Are you using commonly the idea of not performing KISS in balloon inflation, or I mean at least pot-side pot in these conditions?
I used to do it every time, and I did it partly, if I'm honest, to get myself better at crossing stents. I then decided I didn't need to do it, and I have been influenced by the data from Japan and for Korea that probably in the left main, it probably is a sensible thing to do. That said, in an elderly patient where you're anxious about the creatinine and you've got a nice result and you've done a pot, I think it's not unreasonable to leave it, to be honest. I think part of the argument people used to say around, oh, well, you may have to come back and, you know, it's best it's left if it's open. I think that's rubbish. You know, I mean, you're going to either get across and do it or you're not. And, you know, and you can image and you can, you know, so I think that kind of, oh, you can't leave it for someone else to kind of have to stumble the way through. I think that's nonsense. The pot, I think, is the key thing, because accessing the circ through a left main stent which has not been properly expanded is very difficult. So making sure that you've done an appropriate pot and you've got an appropriate expansion of the stent within the main, I think, is the key thing. Kissing, yes, certainly in a younger patient I probably would have, but in an old patient like this, I can understand why we didn't.
So I like very much this comment because, I mean, we were discussing, we are at PCR, a lot about angiographic images. But, I mean, we have patients, and we cannot accept that the course of a PCI is not influenced by, I mean, clinical important factors like the age of the patient, the conditions, I mean, the comorbidities. Here there was aortic stenosis as well. I mean, we discussed about, in a similar case, the first one, about the opportunity to have a cardiac assist device. If you have valvular heart disease, it is not easy, I mean, to add on in the case you have complications. So I think all of this stuff is inside our practice, and we should really emphasize about the fact that the flow of our PCI should be adapted as much as possible to the patient we are treating. This is, in my mind, very important. So, do we have questions from the audience? I mean, you are a little bit lazy with the, with the system. Let's try. In the case there is some question, you may go on. Alternatively, do we have burning questions? If not,
there's a question about whether the optimal trial recommends imaging pre-procedure. It recommends it strongly, but not strongly enough to make Dr. Hildesmith do it.
Yeah, it doesn't mandate it.
Well, and because it's English, he picks the bits out of the words that he chooses.
Yeah, no, well, there's a big difference.
It's strongly recommended, I think.
Well, I only saw the word recommended, actually. But,
opens brackets, please do it, Dave, but he didn't do it.
Yeah, no, well, the thing is, I mean, we could discuss that. I mean, the left main was pretty tight at this distality. I mean, hands up who would have definitely done the IVUS at the start? You see?
Just one.
And so who would have done it after pre-dilatation? Yeah, see?
I did that.
No, after you put the stent in.
Oh, yes.
Okay, so too late. And also, maybe, I mean, not too late in this patient, but I think that, I mean, what is actually recommended, I mean, according outside the protocol, but in the clinical practice, is the fact that the use of imaging is strongly recommended in left main interventions. And for sure, we may insert our imaging modalities in different steps of our procedures. Most of the time, as soon as we are able to do it safely, it will simplify the next steps. This is what we may say from the practice. So in this case, it was probably performed in looking for safety. It means not ischemia related with the device trying to have imaging. I catch this benefit, but once you are ready to deliver the stent without having prepared at the best your lesion, sometimes you are disappointed about the result and you fight to fix the under-expanded stent as well. Okay, so we move to the case 3. This case will be an image-guided left main PCI, and the case was enrolled in the ROLEX study. The case I want to share with you is a male, 77 years, diabetic, hypertensive, dyslipidemic patient. He had a recent ischemic stroke with full recovery, and he had the right carotid stenosis diagnosed. So he was sent to our facility for the cardiac workout, showing normal echo and documentation of wide inducible ischemic area in the anterior lateral wall. So he was sent to our cath lab to perform carotid stenting and coronary angiography. So this is the diagnostic angiography we performed, and it showed really, this extensive disease inside the distal left main, extending into the circumflex, and also, you see that all the proximal part of LAD was involved. You see here how tight was the lesion into the end of the proximal LAD. So we stopped, we discussed together in the R team, and the decision was due to the fact that the patient had a recent cerebrovascular accident, and the proposed treatment should have been a combined, probably, surgery. We decided to perform PCI, and he was enrolled into the ROLEX study. So PCI was planned electively by right radial approach, 6 French guiding catheter, and workhorse guide wires. This is the image we get with the guiding catheter. Most of the time with the guiding catheter, you see much better vessels, and you see that there is really tight disease in this distal left main and tight disease into the LAD. So the LAD was treated without predilating the side branch. It was easy to cross with non-compliant balloon to predilate, surprisingly, let's say. And we implanted the stent, and we optimized the stent with post-dilation. And after that, we moved to the left main. Since there was no ischemia delivering the balloons and the stent, we performed imaging without predilating the left main. So, we followed the recommendation by the Japanese colleagues as well. And we used OCT. So in this case, we performed OCT in both directions because really the disease was extending in both directions. This is the pullback. First of all, I want you to see how clear is the OCT image. It is very important. If you select, instead of IVUS, that is the gold standard, OCT, you should be able really to have fantastic images. Alternatively, it doesn't make sense at all. And what we got from this was how tight was the lesion into the very distal left main. So the confirmation was there. It is not a matter of eccentric or hazy lesion. It is tightly stenosed into the distality. And on the left circumflex to left main pullback, we recognized that there was some calcium into the proximal left main circumflex, and here you see the very ostial circumflex with the LAD on the side, showing that there is a lot of plaque in that direction. So for sure, this is a situation in which we cannot implant directly the stent. What we did is, as I mentioned during the discussion, let's start with non-compliant balloon. At that stage, we had in mind the size of the reference vessels, so we decided to predilate with non-compliant balloon, sized 1:1 to the possible stenting we were going to implant in the both direction. We did it sequentially, and so far there was no discussion in our cath lab about which is the technique. According to the ROLEX study, it was possible to select the best for the patient. Most of the time, we discuss a lot about the technique to implant the bifurcation stenting before, but we think really
But Francesco,
that
you were committed to two stents.
Sorry?
You were committed to 2 stents.
Yes, we are committed. No, we are open to put either single or 2 stents according to our technique. The only suggestion by the ROLEX study was to follow all the best practice by EBC according to the technique you are selecting for your patient. Okay, so this is what we are doing in our practice. So we decide in our patients to select the technique after having prepared the lesion. And you may understand the fact that here we have a lesion that looks much less complex as compared to the beginning. And this is the result of good pre-dilating process that was successful. So at this stage, in our lab, we like very much the flow of provisional. And if we look at this magnification of the angio, we have a key question in my mind. If you are performing provisional, you are crossover stenting another branch. So which branch has a higher occlusion risk? We don't want to have an occlusion, a sudden occlusion, complete occlusion of a large of these 2 branches. In this particular case, you see that there is this extensive dissection coming from here and standing here. So our feeling was that to implant a stent from here to here, having the risk of having to rewire a extensively dissected vessel can be a problem. So this was our perception. So among the different possibility of provisional, that is provisional or inverted provisional, A or inverted A, according to your selection, we decided this should be the operative main vessel to be stented first. And we did it. So we moved in the cranial view. We implanted the stent to cover up till the previously implanted stent up to the ostium. This is the phase in which the stent was delivered. You see that there is full expansion after this lesion preparation in this case. And then there is another important step in my mind if you are adopting the provisional in these complex cases, to perform an angio check before performing a POT. Why? Because if you have occlusion here, you have here the stent that is fully malapposed, you didn't perform POT, and you may restore immediately the flow by advancing a balloon. If the flow is good, you may go on with the next step that will be POT. We had the OCT to guide, we selected a 5.0 balloon, and we did twice. The first ballooning was close to the carina, then we moved back to be sure that all the stent was fully apposed. This is very important. We don't want to have the malapposed stent preventing the safety of guiding movement inside the artery. And after that, we performed the rewiring. A third wire was advanced first into the distality, and then with the pullback technique, we entered very beautifully close to the carina as soon as there is no wall, so the ostium of the circumflex. With this technique, the chances to go distal are very high, so we dilated it. We dilated also with kissing, and then we moved forward to tap stenting. So in doing this, one of the main concerns for people that doesn't use this technique routinely is how will we be able to deliver the stent in the side branch since I have to cross? Okay, so if you have dubbed, I had the possibility to acquire how, following all the steps, you may go easily inside this side branch, despite the fact that there was some calcium at the beginning. So good lesion preparation and good rewiring translates in this.
Can I ask?
Yes, you can.
Did you consider stopping at that point? I mean, was there an angiogram and how did it look?
So honestly, in this particular case, we decided not to do because the lesion started at the beginning was worse in the circumflex. It was I mean, I didn't showed the aspect after the redilation, and there was, I mean, some residual.
Can I ask Professor Murasato that there is IVUS data from Korea about the state of the circumflex in crossover stenting and how that predicts the need for a second stent. Is that how, do you use OCT in the same way in your practice to determine whether a second stent is likely to be necessary by imaging the side branch?
Yes, of course. So after pre-dilation, we perform the OCT. If the side branch dissection is severe, the side branch stenting should be done. In my daily practice, I perform the OCT before the members stenting or side branch stenting. So according to the pre-PCI finding, I decided my strategy, one stenting or two stenting.
Okay.
And do you base that on the minimum lumen area as well as the presence of dissection, or the plaque percentage plaque, or what's your cutoff for a second stent?
According to the angiography, I think dissection is minor. I think my opinion. The check the dissection level is very important. If the dissection is minor, I use DCB for the ASX ostium. However, dissection is very severe, type B or more. I should the side branch stenting. So in this case, I perform the Curo technique. Actually, the LED is very crucial. The Curo stenting, firstly, members stenting, LM to LED, and then the SX stenting I select in such case.
Thank you.
Okay, so on the opposite, we went through with the TAP technique. According to the technique, it is very important that you really deserve attention in a meticulous way to end up with the minimal protrusion inside. So the uninflated balloon is left into the LED distally, and then all the concentration is here. And you should also know the relationship between the marker that is more visible and the stent struts. You may also use the stent magnification to see really the relationship between the stent you are going to implant and the stent you already implanted.
So Francesco, you're the expert on TAP. And when I was first told, I was told that the stent marker should be on the wire. Now, clearly that's too distal, right?
Yes.
Sorry, too proximal, should I say? Yeah.
So, and also it is important to remember the fact that from manufacturers to another, there is a remarkable difference in this distance that may cause too protrusion or uncoverage in the case you do not rely on the device you are using. So, according to TAP, then when you are satisfied, you deliver your stent, and this is the phase in which it is delivered. Then what we recommend doing is to pull back the balloon of the stent and to expand it at very high atmospheres to have the stent stenting optimized. You see how at higher atmospheres this balloon increases. And then after that, having done this, you pull back your balloon and you perform simultaneous inflation and, more importantly, simultaneous deflation. Why it is important? Because neocarina, you do not know how long it is, and it will be displaced in the opposite direction of the last balloon you are deflating. So it is important to keep attention about that. And then we enter in the discussion about repeating or not POT. Repeat POT with many double stenting technique is something that is done, is recommended to be done, but with the TAP there is an issue. we should really stay away from neocarina because we may jeopardize the result here. So if you decide doing, you really need to stay away. We decide doing, you see that we took a bigger balloon, let's say a 5O semi-compliant balloon at high atmospheres. That means that we will have the benefit of the compliance of the balloon to go higher atmospheres, but we were very far from the possible neocarina. This is what you may expect to have in the visible art. When you have T-shaped angulations like that with TAP, you may have really only a small crown of protruding stent struts. This was the result by Anjo, but we had the OCT machine, so it is really time to investigate. And we performed the OCT. Here you see again, I mean, how good is the clearance. This is the three-dimensional reconstruction showing how in the LED the stent adapted well to the two sides. And this is in the left main, the fact that we really reached more than 5 millimeters with perfect apposition and expansion. And then also we checked the carina level. It was just, look where we are, really at the carina. So there was only a minor protrusion. And it is very important, the fact that we recognize that the ideal TAP is T. The problem is that you recognize at the beginning, but you will deserve to have this aim during all the steps of your procedure. So this was the case, but I would like to put it in today's perspective. At Late-Breaking Science, there was the presentation by my friend Giuseppe Tarantini about the ROLEX study. This study is, in our mind, very important. Many centers in Italy and Portugal, 450 patients prospectively treated with the Onyx stent, using the best technique according to the operators, and the imaging was performed in half of the procedures, less than half. OCT was really rarely used, but it was used as well by experienced center with that, and single provisional stent was used in the majority of the cases. The target lesion failure at 1 year was 5.1%. I think that this figure really deserves attention because it is something that really is remarkable if you put it into the perspective of the numbers we are using to see in the trials at PCR and other areas. And this is one of the main messages. There was a predefined sub-study comparing angio-guided PCI with IVUS or OCT-guided PCI, and this is what we got. The primary endpoint was really improved by that. Moving forward, if we put EBC and ROLEX, we have this kind of double stenting technique, for sure in the EBC main, where the focus was complex lesions only. There was a higher rate of double stenting, but SKS not used, and DK crash was used in the minority. So in Europe, we are working like that. And if you look at the two stent techniques selected by the European operators in EBC main and ROLEX, you will see that culotte and T-tap have been used a lot, DK crash a minority. This means that the vast majority of patients receiving double stenting have been treated according to the flow of provisional. That is part of, I think, the experience we wanted to share today. Thank you for your attention.
Fantastic results. I'm going to have to look at those in greater detail now. I'd be very interested to read that when it comes out. I mean, first comment, again, slightly surprised that the imaging was 40% again. So yes. We see that DK Crush 5, it was 40%-ish, EBC main, 40%-ish. So even though we've moved on, 8 years or something since DK Crush 5, still only 40%. What do you think that was?
The problem is reimbursement. I think that the Japanese colleagues really fixed well, convincing their government about the need to have reimbursement for imaging. Isn't it?
Yes, we perform the left main PCR that almost 100% imaging guide. Yeah.
Okay, thank you. So, David, I think that it's time to close. I leave you to close the session. You have 30 seconds to say hello to the
right.
people.
Well, thank you very much for coming and joining us in this session. I hope it was educational and interesting. There's another session starting straight after this one, so I will leave it there. Enjoy your evening in sunny Paris.
Thank you very much.